Gwen?
It's recording.
Ladies and gentlemen, good morning, and this is the monthly Excel PAD webcast, and we are delighted to have Dr. Tayo Ado, who is the Associate Professor at University of Texas Southwestern Medical Center, a renowned interventional cardiologist and peripheral interventionalist, and who is also the Program Director for Interventional Cardiology Fellowship Program at UT Southwestern Medical Center, and a close friend of mine. So we are delighted to have him. Tayo, welcome to the Excel PAD webcast. We are eager to hear from you. The topic today is covered stents for long or lengthy SFA stenosis, and SFA stands for superficial femoral artery. So this is going to be a very interesting topic. And I'm sure Tayo has lots of good information for us, and I invite, as always, to keep the meeting interactive. We will start promptly at 7:45, and we'll try to end at 8:15, and we will have some Q&A within that time. And if you have any questions, please don't feel free to interrupt us and Tayo, and I'm sure Tayo would not mind any questions. I also request each one of you to mute your lines. You can feel free to unmute them if you have a question, or if you are connected via online on WebEx, you can always raise your hand online, and then I will, of course, give you the time to ask that question. So take it away, Tayo, and welcome again to Excel PAD.
Well, good morning to everybody, and thank you, Subhash, for that kind introduction. It's a pleasure to be given this morning. I've always enjoyed these discussions. You have an incredible group that participates in these monthly meetings. So thank you again. So I'm going to try and address this topic, covered stents in the SFA. It's not something that has taken off in great popularity, and the question is why? Is there just insufficient data or problematic data? But I hope by the end of the discussion, I might show you that there might actually be some interest in exploring this further as we continue to tackle this very complicated part of peripheral vascular revascularization. So when do we consider covered stents? We've known for a good while now that these are very valuable when there is an obvious perforation, or when there is a high risk of perforation, particularly when you re-enter in a high-risk location, such as the iliac arteries or the aorta. It's been very valuable in helping exclude aneurysmal segments, either focal or diffuse. Some people have considered it in thrombus-laden occlusions, just to exclude thrombus and reduce the risk of massive embolization. There's been interest in using this for diffuse in-stent restenosis with a number of case series that look actually promising. I'm going to focus on the last topic here, which is long lesions in the SFA that are at high risk for restenosis. We know them. These are TASC C and D lesions with very long segments of stents required. We know that bare metal stents have not been the best solution here, and we're always looking for ways to improve our revascularization at this site. Now, the concerns about covered stents are well known, and I put a question mark here because I think some of these may be a little bit exaggerated, and new devices actually have tried to address some of these concerns. They're thrombogenic, and obviously they thrombose. The implications are greater, possibly because collaterals are lost when you implant these stents. There's been suggestion that there is no difference in restenosis with these covered stents versus bare metal stents, and I'll try to share some of that data. They may not be flexible enough to implant in, the highly tortuous and complicated distal SFA, as we know, and they may be too bulky to deliver. But I think there are legitimate challenges to all these concerns as these have improved. The early experience with these stents was mixed, and that was primarily because of the results of the Vibrant trial. This was one of the biggest first randomized trials using covered stents in the SFA. It really used a first-generation device, and the device I'm referring to here is the Vibon stent. This stent was non-heparin coated at the time, did not have a contoured edge, which I'll talk about. It was a little bulky to deliver, and there were some acute complications during procedure. 148 patients were enrolled in this trial. They had a lesion length on average of 19 centimeters, and task C and D by the original task definition were included in this trial. A good 60% of these patients were occluded vessels, indicating complexity. And there was moderate to severe calcification in the majority of patients. So these are the very types of patients where we struggle with and we're looking for ways to improve. Well, the results of Vibrant were negative. The primary outcome, which was at 1 year, was negative, and follow-up out to 3 years essentially found no difference in efficacy between the Vibon stent and bare metal stents in terms of primary patency, which were actually pretty low at 3 years. And you can see ranges in the 45% to as low as 20%. Obviously, when looking at primary assisted and secondary patency, the rates are much higher. But again, no clear advantage, certainly no advantage over nitinol bare metal stents or bare nitinol stents, and so we just thought, following these results, that this Vibon stent was not likely going to be a major force in this area. Now, it's very important to note that the Vibon stent has undergone significant revisions, and it's now probably a more attractive platform. Importantly, they created this contoured edge. This was the site where restenosis was typically seen with these stents. And they've also coated the PTFE with bioactive substances, heparin, so that it is much less thrombogenic. And some revisions were also made to the PTFE itself in terms of allowing it to be a little bit porous, so that all your collaterals are not completely lost. So this new stent design has now been studied further in a series of trials. The first two I'm going to talk about briefly are actually comparisons against surgical revascularization. The surgical arm here using PTFE diaphragm bypass grafts, and they recruited 50 patients in each group, primarily C and D again. And when you look at primary patency at 1 year, this was improved. 74% with the Vibon prosthesis, 74% with surgery, no difference. And secondary patency also high and no difference. And at 2 years, we also see that the patency, the primary patency, remained acceptable, 63%, and no different from the surgical arm as well. There's another surgical type of very similar surgical trial that was conducted and led by Dr. McQuaid. Also, very similar group of patients with primarily TAS C and D lesions, comparing the Vibon patency with bypass surgery. And there's now 4-year data. These were actually fairly long lesions, mean stent length here of 25 centimeters. And you can see the primary patency out to 4 years of about 60%. and no difference between the stent graft and PTFE bypass surgery. So, I think even with these data, there were still some questions about how this will perform against bare metal stents, since bypass surgery using PTFE grafts are just no longer popular anymore. We needed additional trials. Well, the ViaStar trial, I think, has shed some insights into this, and there is now a long-term follow-up of this. 141 patients in this trial, and enrolled patients, again, with primarily C and D lesions, although they did include some B-type lesions of the SFA. Randomized them to the Viabahn or a nitinol bare stent of choice. And if you look at the characteristics, again, they're very typical of what we see. Chronic occlusions in 70 to 75% of the group. Lesion length 170 to almost 200 millimeters. And the stented segments of over 20 centimeters. Again, TASC C and D lesions comprise 50 to 60% of the group. So here are the results of ViaStar. So for the overall trial, by intention to treat analysis, the primary patency rates, again, were comparable, and again, about 60-65% through 12 months. If you then focused on patients who had really long lesions, so lesions greater than 20 centimeters or 200 millimeters, you then start to see a difference, such that they appear to be an advantage in favor of the Viabahn prosthesis compared to bare metal or bare nitinol stents. So this was, one of the first suggestions that they might be a role for the Viabahn stent in these very long stented segments. Again, here the numeric data that I just showed graphically. Primary patency at 24 months now, with Viabahn 63% versus 41%. So the bare metals, they really dropped off after between a year and two, which we've seen in other trials as well. And if you look at the really long lesions, particularly those who actually got the Viabahn stent in the per protocol analysis, 65% primary patency versus a dismal 27% in the bare nitinol. Highly statistically significant. TLR rates, which were not, powered to detect, also favored Viabahn at 80, freedom from TLR 80% versus 62%. Again, p-value of 0.13. Now, the Viabahn, the makers of Viabahn have also reported registries looking at very long lesions. So here is a 25 centimeter Viabahn study where they prospectively collected those who were undergoing revascularization with Viabahn who had lesions certainly greater than 20 centimeters. In this case, the mean length actually 26 centimeter. And when you follow these group of patients out to a year, again, all TASC C and D lesions, they saw a primary patency of 67%. Importantly, the secondary patency was extremely high, 97%, and part of the reason is when these stents do develop restenosis, they tend to be focal and easily retreatable. Now, I think the biggest complicating factor now would be how would this Viabahn stent perform against the best technologies we have for SFA revascularization. I'm sure the audience is very familiar with the data from the Zilver PTX, and now we have data out to 4 years showing fairly good primary patency results when compared to either optimal angioplasty or bare nitinol stents. We don't know whether Viabahn will be as good as the Zilver stent, but it's the numbers are in the range where certainly a comparative trial is desperately needed. This is just a slide showing the data from the Zilver PTX, particularly in really long lesions. Some have previously criticized the original trial, indicating that it limited, or most of the lesions included were on the short side. But even for long lesions, so lesions here greater than 15 centimeter, a mean length of actually 226 millimeters, they show at least in this registry, no recent stenosis was reported. Pretty impressive. So clearly, this is a trial, or this stent is a major player for long lesions, and we would like to see how a covered stent compares with the Zilver in very long lesions. So I throw this slide up here, which has been shown at a number of conferences, and looks at, again, all the major trials you're familiar with using nitinol stents, drug-eluting stents, and the Viabahn stents, and how their 12-month primary patency compares, particularly with lesion length. I will point out again, the vast majority of the trial data involves fairly short lesions. As you can see here, less than 15 centimeters. And in those trials, finding an edge of one over the other is relatively difficult. Maybe perhaps the Zilver stent does well there. But when you get to the much longer lesion studies, we have much more limited data. With the Zilver long lesion, a patency of 75-77% has been reported. That was followed next by Viabahn, it's about 67 to 68%, and bare metal stents still track just a little bit lower. The best data we have was from the Durability 200, which shows a patency of about 65%. Again, just to put some of that graphic again in a table, so you can appreciate the lesion lengths in some of these trials. For the Zilver PTX long lesion study, length of 226 millimeters. Viabahn has the longest, actually, 265 millimeters, and the Durability bare metal 242. Primary patency 77%, 67%, and the bare metal 65%. And those results track with the TLR rates. So it seems like, at least from this limited data, Viabahn falls somewhere in between what you would get with a Zilver and bare nitinol stent. Although these are not head-to-head trials, these are different trials, patients, and comparative trials are definitely needed here. Just to add in one more stent to the mix, and that is the advancements with the nitinol stents. The Supera stent, although again we have very little comparative trials, is reporting remarkably high primary patency rates. And as you can see here, in some of their registries, they're reporting patency rates of close to 90%, 80 to 90%. That is certainly better than most of what we've seen and presented so far. So I think this stent definitely works very well, perhaps better than standard nitinol stents. But will need to also be compared against, say, a Viabahn or a Zilver PTX stent. Here's an example of one of these registries, the Supera 500, led by Dirk Schernert out of Germany. Here you see again, task C and D lesions primarily, patency rates at 1 year 84%, at 2 years 73%, and even when you look at the lesions greater than 150 centimeters, 81% and 68% at 2 years, also pretty good. I'm going to throw in just briefly the drug-eluting balloons. The data here is very limited, but Tom Zeller at the most recent meetings have shown this data. I'm not sure if it's published yet, but they've used a retrospective propensity score matching analysis of what the drug-eluting balloons will do against the Zilver PTX stent, even in fairly long lesions, approximately 19 centimeters. And at least he's reporting that they should compare just as well. Again, I think this is very preliminary. We really need to see a dedicated trial of drug-eluting balloons in these very complex SFA lesions, and preferably a comparative trial against the drug-eluting stent. Finally, I just want to touch on adjunct therapy. If you do select a covered stent, there again, I mentioned there's always been a concern about acute thrombosis, and that can have devastating complications. Can that risk be reduced? We think by more aggressive antiplatelet therapy that may be the case, although we just don't have the data to really prove this yet. I know, Subhash, you're working on this in a great trial to compare short course versus longer course dual antiplatelet therapy. These are data that are definitely needed as we move to more long lesions, very complex long stenting, particularly with covered stents as well. But people have used various things: aspirin and clopidogrel, and cilostazol, as well as aspirin and warfarin therapy for these covered stents. So I think I've probably mentioned some of these points. I think the long segment complex SFA disease remains a therapeutic challenge. Unfortunately, we see it very often in our practice, and the standard bare metal nitinol stents have just not been the optimal solution so far. The primary patency rates, particularly once you start getting up to 2 years, really drop off. And when these stents reach stenosis, they tend to be very diffuse, fairly extensive, and retreatments have not always been very good. The drug-eluting balloons, they do appear favorable in their trials so far, but I think we don't have the data yet for these very complex FFA lesions. Certainly, the very long, greater than 20 centimeter lesions that require very extensive stents. So we need to see how they perform. The PTFEs, covered stents, the Viabahn in particular, I think may be a reasonable consideration based on the trial we have for these complex lesions. They seem to compare to the Zilver PTX drug-eluting stents, and perhaps maybe better than current standard nitinol. But what we definitely need, as the entire group is well aware, is we need more definitive trials. We need good comparative trials between Zilver PTX, drug-eluting balloons, and best-in-class bare metal stents, perhaps the Supera stents. That is what is needed to really determine what is the ideal first-line therapy for these complex, lengthy lesions. So I'll end my talk now, and let me open it up to comments, questions, and discussions. Thanks again, Subhash.
Thank you, Tayo. This is a phenomenal review of the entire data regarding covered stents, and I appreciate that you started from Vibrant-1 and emphasized the technological changes that the Vibrant stent has incurred over the last many years. And I also thank you for reviewing the most current up-to-date data, and some of it not published yet, from Dr. Zeller's group, who have done phenomenal amount of work with the covered stents in the SFA. I think I just want to add two comments, and please correct me if Tayo. And number one is that the technique of deployment of covered stents is a relevant area, and I think in the next few minutes, if there are any callers who would like to comment on it, I would appreciate. I think paying good attention to areas of landing zones of these stents is important. I think that any obstruction or lesions or residual lesions at the outflow of the stents can have an important impact on the patency of these stents. And of course, Tayo mentioned the need for antiplatelet therapy and post these procedures. The other thing which is important is the proper sizing of these stents, and I think that I would go along to say that preparation of the vessel prior to covered stent implantation is also extremely important, and I think in the prior webcasts we have discussed many of those issues. The one thing that was pretty striking in the subsequent Vibrant trials, not Vibrant-1, is not very high rates of stent thrombosis and acute limb ischemia, which had been a concern in the past. So I think all these are positive signs, and what Tayo has done is to share with us in that in the last half a decade, there has been an explosion of different forms of therapy for the superficial femoral artery, which again goes down to point out or emphasize that this is a very vexing area where no ideal one solution can be found, and I think our job as clinicians is to find the best treatment option for a particular patient and a lesion. And again, comparative trials in this area would be highly welcome. So, Tayo, thank you again, and any comments from the audience I would greatly welcome, but if you can share, Tayo, in the few minutes some tips in terms of the technical deployment of these stents, I think it would be very helpful to the audience.
Oh, yes, Subhash, you made very great comments there. The technique is very important, and I think that was part of, why the early experience was not very favorable. High rates of restenosis, particularly at the edges, and that's because, we had disease that was left uncovered. These were focal restenosis, but they were pretty severe restenosis when they happened. I think for thrombosis, vessel preparation is very important. These stents have to be very well expanded. They're not as forgiving. For bare metal stents, we tend to leave 20-30% residuals, but you really want to expand these stents when you implant them. And the antiplatelet or antithrombotic regimen is also important. We need more trials there to guide us further, but clearly short course or single antiplatelet therapy does not appear sufficient for this device.
Thank you, Tayo. One additional point, and anyone like to jump in, is that there has been a lot of use, at least anecdotal reports, of using covered stents to treat bare metal stent in-stent restenosis. And I've personally witnessed those and have seen many such case reports. However, there has not been a very large systematic analysis of this, and I think any comments from you, Tayo, would be important. And the other thing I want to point out that we have from the XLPAD group, we have two significant papers coming out. One in the Annals of Vascular Surgery. Just stay tuned about antiplatelet therapy use and duration. This is from the XLPAD registry, not a randomized trial, in terms of patients with infrainguinal treatment with stents and without stents. And the second paper, which is currently in review with Circ Interventions, is about the incidence of stent thrombosis from the XLPAD registry, amassing data from over 900 patients. So I think please stay tuned for those publications. But Tayo, any comments about using covered Viabahns for treating bare metal stent in-stent restenosis? I'm sure you've seen it.
Yeah, and if anything, that appears to be the single largest use of these stents today. It's clearly in the literature. They're a nice series of up to 100 patients from multiple centers, led by the German groups, and they've had good experience with recurrent rates much lower than what you would expect with balloon angioplasty, laser therapy, or some of the other considerations. Yes, definitely experience is out there for ISR, diffuse ISR. I think in those cases, again, lesion preparation is key. You really will have to debulk and possibly further expand the old bare metal stents before implanting a new covered stent for the best results and for safe results. But yes, that indication or that experience is now comprising the largest use of these Viabahn stents. Anybody else in the group with experience? We haven't used it much, maybe in a case or two, but we've definitely seen it in the literature.
One final comment is, in interventional cardiology and endovascular therapy, sometimes you have to use devices just to be able to use it when you absolutely need it. So I think the use of Viabahn when one has a perforation or any other situation where you absolutely need to use it, I think it's good to have some hands-on experience with these devices so you can actually deploy it and take care of it, take care of the lesion in quick succession. So I think this is a great review, and with some important technical tips and a landscape overview provided by Tayo. And Tayo, I greatly appreciate this. I just want to remind that the entire presentation will be posted on XLPAD along with a reference article from Dr. Addo and two multiple choice questions. So please visit www.xlpad.org to continue this conversation and share your comments and opinions. So thank you all for coming in this morning. I again thank Dr. Tayo Addo for taking the time out to share with us his wisdom on long, complex treatment of SFA, especially using covered stents. Thank you all.
A pleasure. Thank you.
Bye-bye.